All right, so now we're going to transition from talking about joints in a very sort of broad manner to talking about specific body joints and the movements that are allowed by those specific joints. So even though synovial joints are diverse, all of them have really general features, but they also have some unique structural features and abilities and weaknesses that we get to kind of exploit. And so we're going to be discussing the 5 main synovial joints, including the jaw, which is also called the temporomandibular joint, the shoulder joint, elbow joint, hip joint, and knee joint. Right, so let's just dive on into these. So the first one is the temporomandibular joint. Fun fact about this joint, it's the most easily dislocated joint in the entire body. It is a modified hinge joint. And in terms of its articulating surfaces, because remember a joint forms when two bones meet up with each other, those bones and markings that are meeting up with each other in this case are the condyles of the mandible, which is this back part of the mandible, is going to meet up with the temporal bone, and there's a specific spot on the temporal bone where the mandible is going to go and kind of sit in. The capsule of the TMJ, I say TMJ, and if you hear me say TMJ, I'm referring to the temporomandibular joint. So the capsule of the TMJ is going to thicken into this really strong lateral ligament, and so that's what you're seeing here, is this really strong lateral ligament that's basically helping to hold the posterior portion of the mandible in place. You can tell by the way that its fibers are running, that it's really holding the jaw, especially the back of the jaw, up in its place in the temporal bone. So the movements here are, remember I just said it's a modified hinge joint. So this is a really rare one in that it actually is 2 joints, joint types. So it is both a hinge joint and also performs gliding action as a plain synovial joint. So in terms of the hinge actions, this is what's allowing elevation and depression of the mandible, which you guys see mine doing a lot right now because I'm talking a whole bunch. And the other movement is the gliding movement. And it's the side-to-side grinding of the teeth that you can perform. Like you can move your jaw kind of back and forth this way. And it's also called lateral excursion. And that's what you see down here in this C picture. In this picture of B, you're seeing the articular disc and the point at which the mandible is actually touching up, meeting up with the temporal bone. So some interesting stuff about the TMJ joint is, like I said, it's the easiest one to dislocate in the entire body. So dislocation is most common because the socket of the joint is actually really shallow, and therefore the joint almost always dislocates anteriorly. So by dislocation anteriorly, I mean it's basically going to move towards the front of the face. The jaw is kind of causing this sort of underbite type of situation. So here's the normal disc position with the jaw being closed, and then the jaw is opened. So if the joint here is dislocated, then the mandible can actually move even more anteriorly, and then it gets stuck because you can see this notch, how it could potentially get stuck if it moves past that notch. And in order to realign a dislocated jaw, the physician actually has to physically push the mandible back into place, and it's horrible. sort of alternatively, and this is something that's a little bit more common, I think, is TMJ disorder. And this is basically a problem that is going to affect the disc. So remember, discs are located in between two articulating surfaces, and they basically help to reduce the friction. This particular disc is a moving disc, which is really cool because whenever we have our mouth shut, the disc is kind of covering up in its space, and then whenever we open our mouths, because the mandible changes position, the articular disc is actually going to move with the mandible, and now it's going to prevent the rubbing together of these 2 points. Okay, so what happens in TMJ disorder is there's some kind of wear and tear that's happening here with the disc. So some of the symptoms here would be things like ear and face pain, tender muscles. Anytime you open your mouth, you feel or hear a pop kind of closer to like your jaw and ears. And then also joint stiffness. Some of the major cause of this is teeth grinding. Whenever you're asleep, people that snore tend to also grind their teeth, and sometimes people just grind their teeth anyways whenever they're sleeping. But it can also be due to some sort of jaw trauma, or if your teeth aren't quite positioned correctly. So in order to treat TMJ disorder, usually you have to get a bite plate, which you would wear whenever you're sleeping, because the most common cause here is grinding teeth. So you wear a bite plate. It's kind of like a mouth guard that's going to help to relax the jaw muscles. So, fun facts. All right, so at this point, we're going to move on to the shoulder joint. And the shoulder joint is the most freely moving joint in the entire body. And this joint is a ball and socket joint. It's going to consist of the large hemispherical head of the humerus that's going to fit into the small, really shallow glenoid cavity of the scapula. And in lab, we've looked at this, and so you guys kind of know what I'm talking about. The joint capsule here is very thin and it's very loose, which provides us a lot of range of motion. So ROM over here stands for range of motion. So by having a really thin and loose joint capsule, we have a lot of mobility in our shoulder, but kind of the downside is its fall is that doesn't really give us much stability because there's not a whole lot of structural support happening. So this is why shoulders can easily be dislocated. So some other parts of the shoulder joint that are important to know and understand are the glenoid labrum, first and foremost, and this is the fibrocartilaginous rim that's going to be right along the glenoid cavity. So this picture is showing you the scapula from, so not from an anterior, not from a posterior, but you're kind of looking at the scapula like this. And so you're seeing, here's your acromion and the coracoid process, and then here would be the body of the scapula. So the glenoid labrum, again, it's going to form this little ring that's right around the cavity, and basically this just helps to add some depth to that really, really shallow cavity that is the glenoid cavity. Even by adding in this labrum, the cavity only holds a third of the head of the humerus in that cavity. So it's a very small, shallow area, which contributes to the lack of structural support for the humerus being held in place. However, we do have some reinforcing ligaments, mostly on the anterior aspect of the shoulder. So for example, the coracohumeral ligament helps to support the weight of the upper limb. So that one goes from the coracoid process it would go down into the humerus. And then we also have 3 glenohumeral ligaments, which is what you see here. There's 3 layers here of ligaments, and they strengthen the anterior capsule, but they're just weak support. So ultimately, injury to the shoulder is possible with a little bit more ease than some of the other joints. So this picture, it's the same sort of slide, but it's just showing you sort of a better picture. The coracohumeral ligament, as I mentioned before, is going to travel from the coracoid process down to the humerus. And then we have 3 glenohumeral ligaments that are sort of reinforcing the capsule. But again, they're weak support. So some more supporting structures of the shoulder, in addition to having these ligaments, we also have some muscle tendons that help to contribute to joint stability. So the tendon of the long head of the biceps brachii muscle is what's considered our super stabilizer. It travels through the intertubercular sulcus and secures the humerus to the glenoid cavity. And then additionally, we also have 4 rotator cuff muscles. So those 4 muscles, if you kind of rearrange the first letter here, it spells SITS, S-I-T-S. So supraspinatus, infraspinatus, teres minor, and subscapularis. And I'm going to play this video maybe for you.
All 4 muscles combine at the humeral head by way of tendons and form a cuff over the joint, hence the name rotator cuff.
Okay, I guess that's all I have for that video. So these videos are going to show you some different joint movements that are present at the shoulder joints.
The anterior scapular muscles that cross the glenohumeral joint are the coracobrachialis, the biceps brachii, and the deltoid. The coracobrachialis muscle originates on the coracoid process of the scapula and inserts on the medial surface of the humeral shaft. The biceps brachii muscle has 2 parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle of the glenoid cavity. The 2 heads of the biceps come together distally and insert on the radial tuberosity, just distal to the elbow joint. The deltoid muscle is composed of 3 distinct sets of fibers: the anterior fibers, which originate from the anterior border and lateral third of the clavicle; the middle fibers, which originate on the lateral margin and acromion of the scapula; and the posterior fibers, which originate on the posterior border of the spine of the scapula. All fibers converge to insert at the deltoid tuberosity of the humerus. The posterior scapular muscle that crosses the glenohumeral joint is the teres major muscle. The teres major muscle originates on the inferior angle of the scapula and inserts on the medial edge of the intertubercular sulcus of the humerus.
So one of the most common injuries to the shoulder joint is shoulder dislocations. And this is just due to the lack of structural support and also the increased mobility of the shoulder. Ironically, the structures that are reinforcing this joint are the weakest anteriorly and inferiorly. And so in addition to this, remember I said the glenoid cavity just provides really poor support when the humerus is rotated laterally and abducted. So when it is rotated so that the biceps is facing kind of up, and then it's also away from your body, your arm. For example, when like a football player would use an arm to tackle an opponent, the glenoid cavity gives us really crappy support in that sort of situation. And in addition to that, the shoulder can be dislocated by having blows to the top and the back of the shoulder. And so this picture is showing you a shoulder dislocation, and you can see the head of the humerus should be up just under the acromion, but instead it has slipped inferiorly and anteriorly. So inferiorly downwards and then anteriorly more towards the front of the body. So here's then just the picture of the shoulder dislocation. So the elbow joint is a hinged joint, and it's actually formed from the trochlear notch of the ulna, which goes on to articulate with the trochlea of the humerus. And the movements that can be performed here are flexion and extension, because this is a uniaxial joint. So let's watch this video.
The forearm flexors consist of the brachialis, the brachioradialis, and the biceps brachii. The brachialis muscle originates on the front distal half of the humerus and inserts on the coronoid process of the ulna. The brachioradialis originates on the lateral supracondylar ridge of the humerus and inserts on the base of the styloid process of the radius. The biceps brachii has two parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle of the scapula. The two heads of the biceps come together distally to insert on the radial tuberosity, just distal to the elbow joint.
Okay, so that's just showing you some of the muscles that allow movement at the elbow joint. So those are the muscles that would be allowing us to perform flexion and extension of the elbow. All right, so let's talk a little bit more about some different supporting structures of the elbow then. So first and foremost is this thing called the annular ligament. And the annular ligament surrounds the head of the radius. So let me get my clicker out here. Laser pointer. So the annular ligament sort of wraps around the head of the radius. And this is important because whenever we're going from supination to pronation, remember I said the radius sort of rotates over top of the ulna. By having this annular ligament, it kind of helps more proximally keep the radius close and sort of attached at this elbow joint. In addition to the annular ligament, we have two capsular ligaments that sort of help to restrict movement in this side-to-side direction. So we would have the ulnar collateral ligament and then the radial collateral ligament. And so you can see the radial collateral ligament here. So I mentioned the ulnar collateral ligament, but you couldn't see it from that last picture. So that's what you're seeing here, is what I'm showing you, the ulnar collateral ligament. This ligament would be, how do I do this? So pinky side of your elbow. So this one actually goes pinky side to sort of like the tip of your elbow. area. And the ulnar collateral ligament is most commonly affected by overuse injuries, like pitching a baseball or playing tennis, so swinging a tennis racket. So this one, injury to here, is kind of usually can be associated with tennis elbow, but one of the most common baseball injuries for pitchers specifically is UCL damage that will then need to be reconstructed, and the surgery that they call that they use to treat UCL reconstruction is called Tommy John surgery. And so this is when then the ligament, the UCL, is going to be replaced by a non-essential tendon from somewhere else in the body. And according, so what's kind of cool about this, according to a study in 2010, about 83% of patients return to their previous level of competition or higher after having this surgery performed. So even if a pitcher, a professional baseball player, does have to have this surgery, they a lot of times can still return to pitching after they've been off for maybe like a year to a year and a half of rehab and recovery. So that takes care of then the elbow joint. So now we're kind of moving sort of down the body, and we are going to talk about the hip joint. The hip joint is a ball and socket joint, just like our shoulder joint was. And the articular surfaces here would include the head of the femur, which is going to articulate with what's called the acetabulum, which is basically this cup-shaped section of the hip bone. So I just mentioned that just like the shoulder joint, this one is a ball and socket, but what's different about this compared with the shoulder joint is that the cup shape on the hip bone is actually very deep. So this is what gives that we have good range of motion because of this ball and socket situation, but because this cup is so deep, it does restrict our range of motion a little bit when compared with the shoulder. We can kind of move our shoulders a little bit more freely than what we can our hips. Another structure that is important to the hip joint is the acetabular labrum. So remember we had the glenoid labrum up in the shoulder, and so the acetabular labrum then is the rim of the fibrocartilage which is going to line this cup. It's going to then just enhance the depth of this socket. And for this reason, because of the depth of the socket, hip dislocations are pretty rare occurring. So in addition to having the structural components of where the two bones are meeting that's already serving as a reinforcement, we also have reinforcing ligaments. So reinforcing ligaments in the hip include the iliofemoral ligament. And so we can see the iliofemoral ligament here. And then, so this is the posterior view. So this is from the back side. So this would be like someone's back side, and then this would be an anterior view, someone's front side. So iliofemoral ligament also has two fiber directions on the anterior side. We have the pubofemoral ligament, which is going to go from the pubis to the femur. So that's what you see here. We also have the ischiofemoral ligament, and so that's going from the ischium, which is the butt bone part of your hip, and that's going to then go in and attach to the femur. In addition to having these, we also have the ligament of the head of the femur. This is called the ligamentum teres. Basically, this goes from so if you're like looking at the head of the femur, it's like circular shaped like this, but right in the very middle of the ball of the head, it's going to have like a little depression, and so that depression is going to have a ligament coming out of it. That's basically going to come out of the ball of the head of the femur and kind of insert into the middle of the cup shape, and this is going to really stabilize the ball in its socket in terms of pulling out the ball. But there is slack in this ligament during most movements, so it's not ultra important for movement stabilization. It's mostly for attachment purposes. You don't want the head of your femur to slip too far away from the cup-shaped section of the hip bone, excuse me. However, there is an artery that is located in the same exact place as the ligamentum teres, which supplies the head of the femur with blood and nutrients. So in terms of the hip joint, most of our stability comes from that deep ball and socket joint, just from the physical structural anatomy of the two bones when they sit together. All right, so I think this is probably the last one, I think, the knee joint. This is the largest, most complex joint of the body because it's essentially 3 joints that are surrounded by one cavity. So we have the femoropatellar joint, and so femoropatellar, this is the femur with the patella, so those bone surfaces are meeting. We also have a lateral joint and a medial joint. So the lateral sides of both the tibia and the femur are meeting up, as well as a medial joint. So let's talk about these. The femoropatellar joint is a plane joint. So remember, plane joints are only allow for gliding motions, and so this allows the gliding movement of the patella across the femur whenever we flex our knee, so whenever we bend our knee. The medial and lateral tibiofemoral joints are the other 2 joints that are going along with the knee, and together they occur between the femoral condyles and the lateral and the medial menisci of the tibia. These 2 joints are hinge joints, which allow flexion, extension, and when your knee is partially flexed, so you're not bent all the way, but you're bent a little bit, the knee can actually rotate just a little bit during partial flexion. So a little bit more about the knee joint. The capsule of the knee joint itself is actually really thin, and there is not a capsule anteriorly, so kind of on the front side of the knee. So instead, the quadriceps tendon is actually going to give rise to 3 really broad ligaments that are going to run from the patella to the tibia. So that's what you see kind of happening here. It's going to give rise to this. So the 3 broad ligaments would be the medial patellar retinaculum, so this section over here, the lateral patellar retinaculum, and then also the patellar ligament. And just to kind of put this in perspective, this ligament here, the patellar ligament, is the one that doctors tap on whenever they're testing your knee reflexes. So in addition to some of these structures, there are at least 12 bursa that are associated with the knee joint. And there are capsular, extracapsular, or intercapsular ligaments that are acting to stabilize the knee joint. So the knee joint has all 3. So in terms of the capsular and extracapsular ligaments of the knee joint, these are going to help prevent hyperextension of the knee and are going to include the LCL, MCL, and then on the back of the knee, we have 2 other ligaments, and these ones are called the arcuate popliteal ligament and the oblique popliteal ligament. So those are located on the back side of the knee. And I already mentioned the LCL, or the fibular collateral ligament, and the tibial collateral ligament, which is also called the MCL. And as I mentioned before, we have intracapsular ligaments located within the knee, and that includes the ACL and the PCL. And this helps to prevent anterior-posterior dislocation of the knee itself. And so the ACL, they're actually going to be named based on where they attach to the tibia. So the ACL attaches to the anterior tibia and prevents the tibia from sliding forwards, and so basically it stops hyperextension of the knee. And the PCL, which is the one that you see sort of behind the ACL, is going to attach to the posterior side of the tibia, and it's going to prevent the backwards sliding of the tibia and the forward sliding of the femur. So it keeps the tibia from sliding too far backwards and femur from sliding too far forwards. So the knee absorbs a really great amount of vertical force, but it is vulnerable to horizontal blows. So vertical force up down is perfect. It's perfectly situated for that, but it is vulnerable to sort of this lateral hit from the side injury. And so common knee injuries usually involve 3 C's. They involve collateral ligaments, cruciate ligaments, and cartilages, specifically menisci. So collateral ligaments, that's your LCL and your MCL. Cruciate ligaments, that's your ACL and your PCL. And then your menisci, your medial and lateral menisci. So one type of injury specifically that I'm going to talk to you guys about is called the terrible triad injury. And so if you have ever, I mean, this happens like more frequently than you would think, especially because of sports, but for example, in this case, we're going to talk about a hockey player and a hockey puck. So a hockey player is standing there with his knee extended, so his leg is straight, and gets hit on the side of the leg, so on the outside of the leg with a hockey puck. Okay, so the lateral blow outside of the knee with a hockey puck. Because of the force, this can result in tearing the ACL, the MCL, and the medial meniscus, because all 3 of these structures are attached in some way or another to each other. So if you tear one, you're much more likely to tear the others, especially the MCL and the medial meniscus, because they attach to each other really closely. They're very closely woven together. These injuries are really common to, for example, hockey players, but also in runners who are changing directions really quickly, like football players who are running routes and then they have to like twist back, or basketball players, sort of the same situation where you're like defending one way and then you cut the other way. This then results in the twisting of the ACL and can cause some severe damage and pain. And in order to repair these, you usually have to have surgery.